Thank you, everybody, for taking the time for our last fellow virtual tumor board session of the calendar year. It's Wednesday. What is it? The 6th of December. Fun day today. We have our topic is the management of advanced and high-risk non-melanoma skin cancers. I want to thank Rob Lindow of Methodist Health in Omaha, Nebraska, and Cal Mannion for their at Vanderbilt for their help in organizing the session. Very excited to have our case presenters, Rob Brody, who will go first. He's out of Penn Med, and Alice Tang will be joining us shortly. I think she just briefly tied up in the operating room from the University of Cincinnati. Also excited to have our guest discussants, Vasudevi out of Stanford and Jen, is it pronounced Cho, out of Vanderbilt University of Medical Oncology. Yeah, thank you guys so much for this. It's going to be a rich multidisciplinary discussion. Really excited about it. Just as a reminder for those who aren't familiar with the format, we'll try as much as we can to stick strictly to 20 minutes per case, just a brief case presentation, and then we'll do discussion with the expert discussants and then the other folks who have joined. Rob will kind of help facilitate that. I'll man the chat box, so any questions from the audience, please shoot them over in the chat. I'll try and bring them to the group. But without further ado, I'll turn it over to Rob. Thank you guys very much.
Yeah, thank you guys, and thank you, Dr. Moore, for all you do for fellow education and getting these programs going. Very good program, and I'd like to thank our panelists for agreeing to do this, and our expert panelists and our presenters. This does take some time out of your busy schedule, and that in December we know how busy we are, so we truly appreciate it. So I have Dr. Brody's slides. So you just tell me what you do. I'll advance when you want to advance, but I'll have you go ahead and start your presentation. And then the way this kind of goes is you start presenting. We have some conversations that if you want to have a question or something out there for the panelist, feel free to ask it, Dr. Brody. And then, but other than that, we'll kind of talk about the case in its entirety as well.
Well, thanks for the opportunity to talk here today. So I brought in two cases, one Merkel cell and one of a locally advanced cutaneous squamous cell carcinoma. This is the first case, which is a patient with a Merkel cell carcinoma, 84-year-old gentleman whose wife is actually an English teacher and who retired before I even got to high school, which I found out the same high school where I went. And so he presented with a 1.5 centimeter left auricular lesion along the superior aspect of the helix. This was biopsy confirmed as a Merkel cell carcinoma. At the time of that initial diagnosis, he had no clinically evident disease, nothing on ultrasound, and so he had a so I guess the first question I was going to ask is what would be the next step in a kind of a small 1 centimeter lesion along the auricle, which is confirmed to be a Merkel cell carcinoma.
When it comes to Merkel cell carcinoma, relatively small, how do you guys go about working that up?
I'm happy to jump in. Adam Luganbiel from Jefferson. Kyle gave me a call this week and asked me to jump in for somebody, so happy to be here. So yeah, something like this, I certainly would want to understand a little bit about the regional possibility of disease. So I see a PET scan here. Rob, looks like you're about to show us some good images, which would be what I would get as well, and understand the systemic implications of Merkel cell being one that can, even though it can be small, can certainly be metastasized. So that would be my next step.
Great. So, I mean, I'm actually kind of presenting this as though I saw this case originally. I only got to this case later on once some of the later data that we'll show has shown up. But essentially, this gentleman saw a local general surgeon. He had a PET scan that was negative beyond the primary tumor. And so he scheduled him for a wide local excision of the primary lesion as well as a sentinel lymph node biopsy. Ultimately had negative margins at the primary site, but then his sentinel lymph node biopsy was positive. And so, we have a Merkel cell carcinoma. PET's negative, but now we have what would be described as a T1 N1A with a clinically occult regional node metastasis, stage 3 Merkel cell carcinoma. And, is an 84-year-old gentleman as well, which kind of, I think, maybe clouds the picture a little bit, although a very healthy 84-year-old. And so what would, the group consider as, next steps in terms of whether we would go ahead with a completion neck dissection or any other types of therapy that, be it systemic or radiotherapy as well?
When you guys,
Sorry.
another question I would throw out there to you, when you talk about the workup, do you get your imaging and whole body imaging before you do the sentinel node or after you do the sentinel node?
Well,
Before.
for me, yeah. So yeah, I'd agree with Adam. I think especially for a Merkel cell carcinoma, I would kind of do that PET scan beforehand. I think for a melanoma that's relatively thin, I think one could argue. I usually don't get a PET scan on melanomas. I'm not sure if the rest of the audience does.
I
Yeah.
agree too. Sorry, Adam.
Yeah, no, just concurring. I think a lot depends on the clinical. One of the interesting things, just for our fellows, one thing I had recently is a patient came in with a melanoma. I know it's a little sidetracking. Same thing for Merkel cell, but in the melanoma case, and the biopsying had done a shaved biopsy or done a really superficial, and it was staged as a T1. So all documentation was T1 melanoma, and you just looked at the lesion and you knew it was a T4. It was no doubt about it. We couldn't get a PET scan because they're like, there's no indication for PET scan in T1 melanomas. But long and short, I think with biopsies, just recognize who's getting them and are they shaved? What's the depth? And is it just a shallow core, etc. But I agree. I tend to tailor the workup based on the degree of suspicion. In this case, for sure, I think at this point here, I'd be curious to hear what Jen has to say, Dr. Chow, about how quickly you reach for immunotherapy here with this positive sentinel node.
I probably wouldn't, to be honest. There is neoadjuvant data looking at Merkel cell carcinoma, where the patients have about 50% response to immunotherapy, but there's no long-term data to demonstrate whether or not that actually leads to survival benefit. And so for the moment, the main indication that I would give this for would be mainly to see if you would decrease morbidity related to a surgical resection. And in this case, this is a relatively, I think probably for the surgeons of like a chip shot, right? So for that purpose, we don't have data that this would actually benefit the patient. The only reason why you would maybe consider systemic therapy is the patient said no to surgery or was not a candidate for surgery. The other thing I would also point out is probably checking a Merkel cell polyoma virus as basically a baseline value as to whether or not you can detect Merkel cell in the serology as a means for monitoring down the road. So if you resect it first without actually having the Merkel cell polyoma virus level checked, then you really don't know if it was ever positive for surveillance down the road.
Great.
So I was
Hey,
going to
Jennifer.
throw that question out there. Would do you check that in all your Merkel cell carcinomas?
I do. If it's negative and maybe if it's a really small lesion, maybe that doesn't really necessarily tell you anything. But if it were like a large lesion and you didn't check on Merkel cell and then you checked it afterwards and it was negative, you really don't know if that was negative because you've removed all the disease at that point. So it is important to check it beforehand. A negative post-op polyomavirus level is very difficult to interpret versus having one at baseline.
Yeah, so this is kind of where I met this patient now. He's kind of staged as a stage 3. He's got a pathologic N1A node there from the sentinel lymph node biopsy. He was then seen by a local radiation oncologist for consideration of radiotherapy in the setting of this without a completion neck dissection. the radiotherapist ordered a PET scan, which is now what we're seeing here. And this is why it's just kind of like that I always hate it when I get the scans that aren't, they don't show the overlapping heat intensity. But on the previous slide, now you can see that there's kind of multifocal disease in the neck just after that kind of single sentinel lymph node biopsy, about a month after, again, that initial biopsy. And so, in that setting, he came in to see us, and I think Dr. Lugenbuehl was kind of foreshadowing a little bit in that we have a kind of a clinical trial running right now where we're trying to treat these patients in a similar way to some of the newer melanoma trials. And so the patient saw myself and one of our medical oncologists, and we gave a dose of a neoadjuvant immunotherapy on trial, and then brought the patient to the OR for a completion neck dissection 1 month later. And so if you go to the next slide, this is, essentially, again, we have that PET CT showing multiple hypermetabolic foci. MRI brain was negative for brain metastases, and we gave him 1 dose of neoadjuvant pembrolizumab. 1 month later, did a neck dissection. And here's kind of a little split through the lymph node, which I did for one of the researchers. We take this tissue and do a bunch of translational research looking at kind of what might predict responses and what's going on in the tumor microenvironment. But you can kind of see on this slide, there's kind of a bunch of, it appears like tumor in there. That was a pathologic, feeling node. In level 4, there was an incredibly firm node that was almost kind of at the junction of the subclavian vein and internal jugular vein right by the thoracic duct, which was really kind of fibrotic. And I was a little bit concerned about being overly aggressive there. So I kind of shaved it away, but left a little bit of that node there, as I worried I would create kind of a vascular injury or give him a really bad chyle leak. And so I'm kind of happy I did, because when we get the pathology back, it shows that there's 0 of what they saw was just 23 nodes, which were negative for viable tumor. There was significant fibrosis and inflammation that was consistent with a regressed tumor. So now you have, I think, what were clinically apparently many nodes in the neck, but now after a neoadjuvant dose of immunotherapy, doesn't appear to be any disease in the neck. So next steps, would anyone consider radiotherapy for this adjuvantly, or just continue the immunotherapy? And how long do you continue the immunotherapy? And curious what others think, probably trying to kind of create correlations to the melanoma literature, but raising that for the group.
Hey, Rob, can you hear me? This is Sarah Rody. I was late. Sorry, still in the OR. What's in your trial? Is it just a window trial, and there's no intent to treat kind of functionality of the effect of the window, correct? Or
so in this window trial, we kind of based it off of, our institution started a kind of a neoadjuvant melanoma trial, kind of similar to that paper that just came out of MD Anderson and other groups, where I think they were giving 2 doses, but we were just giving 1 dose, and then they base either intensifying systemic therapy on whether there's at least I think it's 70% responsive necrosis of the tumor in terms of what's left with viable tumor. And so we just had a patient review today. They only had 10% viable tumor, and there was kind of a question of what we do next in that regard. And so this trial is very similar in that if they have a very robust response, they just continue immunotherapy. And then if there's not really a response, or there's very minimal necrosis, then we'll kind of consider either increasing systemic therapy and also adding in radiotherapy.
yeah,
So there are,
oh, go ahead, Jennifer.
I was going to mention, so there are like perioperative clinical trials. I mean, I think it's exciting. Like if you have a clinical trial, I think it's completely reasonable to put the patients on immunotherapy, particularly because the neoadjuvant study here is only 1 dose, and you're really not probably affecting, surgical outcome, because it's probably about the timeline it would take to get to the OR. And so in that scenario, it's very reasonable to try to put them on a clinical trial. There is an adjuvant study that was recently published, ADMEC 0, looking at adjuvant nivolumab. And there was an absolute risk reduction for these patients, about 9 or 10% for these patients. And this was there are some flaws to the study, but it does raise the question as to whether or not there's benefit in survival for these patients and potentially minimizing toxicity. There was a significant bias towards patients who went on the observation arm of getting radiation therapy versus the patients who went on the immunotherapy arm who did not get radiation therapy. But the patients who got immunotherapy, they could also have radiation. But that basically underlies, though, that the immunotherapy arm still had benefit over adjuvant radiation therapy. So that does imply that there's some benefit in giving immunotherapy, at least in the adjuvant period, for survival benefit. The problems with the study, though, is that it basically included all stages of Merkel cell carcinoma. The data is very muddy according to stage and things like that. So it's not powered to know if specific disease populations in Merkel cell actually benefit owing to the rarity of the cancer. So it's not appropriately powered to demonstrate that, but it at least implies that the adjuvant immunotherapy would provide benefit. The question then becomes more of like, are you going to actually get benefit in like stage 1, stage 2, especially? I tend to be more biased in giving adjuvant immunotherapy in like higher stage patients, stage 3 for these patients. So, but there's not strong data. I just tell that to the patient though when I tell them that.
Sorry to be late.
Do you use viral loads at all in your study?
Yeah, I believe, we're drawing Merkel polyomavirus serologies in pre and post.
And is that, do you use that to dictate the care at all, or?
I believe, I apologize for not being that well versed. I think it more dictates surveillance and the degree of kind of how frequently we're looking for a site if it stays elevated. But I don't think it alters whether we're kind of adding in radiotherapy or kind of intensifying systemic therapy.
So outside of a trial for our fellows, so we don't, I mean, I could talk about this trial forever because I think it's a great idea and I love the concept. But for our fellows, what would you guys, from our panelists, how would you treat this melanoma? What would you say the standard of care is? You have a T1, N1, gets a PET scan, has multiple lymph nodes. What would you say the standard of care therapy is for him?
I think you meant Merkel cell, correct? Unless you were.
Sorry, Merkel cell, yeah.
Okay, yeah.
Sorry.
Are you asking the fellows, or are you asking us?
The panelists.
Okay.
Yeah.
I believe the radiation oncology, I mean, adjuvant immunotherapy is not considered standard of care just for all the reasons I just stated. So and I'm not sure that we would have to have a much larger trial to demonstrate that benefit. So anything that we would offer in terms of immunotherapy would be considered off-label. Like we would have to get pharma to basically give patient assistance and donate the drug, essentially. So it would not be considered standard of care. So that has to be really consideration. And for us, you'd have to discuss that with the patient because we do jump through some hoops in trying to get it in the adjuvant space. I just make sure that the patient really understands like the limitations of the data that we do have. But I do, in certain cases, advocate for them to get immunotherapy in the sense off trial.
Yeah, from a fellow perspective, if you think about a board question in this setting, I mean, it's really exciting to see what's happening in immunotherapy, but I think the standard of care still has not changed based on all the trial data out there. So I still think my board answer would be surgery, neck dissection followed by adjuvant radiation therapy in the setting of just local regional disease if there's no distant disease on the PET scan.
And ipsilateral only.
Sorry.
Ipsilateral neck only you would do.
Mm-hmm.
Right.
Yeah.
Yeah, and I would agree. I mean, if this was a year ago, that would have been the exact same plan. It would have been a completion neck dissection and radiotherapy. But yeah, I thought it was just kind of interesting to bring this up. Kind of, it was a new trial that came on board, and this is more just a pilot thing, but certainly it would be an interesting kind of cooperative group trial to expand it to a larger group of patients.
I agree. I saw Dr. Mannion's on too.
Yeah, sorry to be late. Can y'all hear me okay?
Yes, yeah,
Um,
perfect.
I had a quick kind of related question for the panelists or anyone else who's on the call. Similar to this response with one dose of immunotherapy, the two patients I've had with the highest titers on their serology, one had complete resolution of their primary after it was biopsied. The other, who had a similar picture to this with multiple PET and CT evident nodes, when we did the neck dissection, they were down to one node with 4 millimeters of tumor in it, and all the others had resolved. And it was after FNA of the initial one. Has anybody else had that experience with kind of spontaneous resolution of Merkel cells? I'm presuming it's immunogenic and driven that way, but it'd be interesting to know as more trials are done if the people that do better with immunotherapy also have higher titers, or if there's any correlation there.
Kyle, great question. I can't say that I have any. The patients I'm thinking of that we've used immunotherapy, I have not. And probably about it, maybe one was a year ago. We did not draw titers on as it relates to this specific question, so I can't answer it. Certainly, we've had the responses you've seen, but I can't make a statement about the serology.
Gotcha.
Well, that was a great. Thank you very much, Dr. Brody, for bringing that up. That was a very good presentation. Is Dr. Tang on yet, or is she
I'm
still
here.
You are? All right.
Hi.
So why don't we go with your one of your cases?
All right. Sorry I was late.
I'm gonna stop sharing, and because you got yours, I'll let you share your screen.
Yeah, that looks right.
All right. So thanks for inviting me. This is good to go through. I have a lot of these patients, always immunosuppressed, chronic hep C, multiple skin cancers in the past, treated by Mohs surgeon, and most recently has a rapidly growing lesion on the left face. Also has a lesion on his lower eyelid, also has a lesion on his left forehead. He is on pretty maximal immunosuppression. He had his transplant for his liver multiple years ago, but they've never really kind of messed with his immunosuppression, even though he's had skin cancers. So on exam, he has this 3x3. It's exophytic. It's not fixed to any bones. He has that ulcer we talked about. I don't feel any lymph nodes on my exam. So I went ahead and biopsied all three in the office. The nasal sidewall is a moderately differentiated squamous cell. The left ulcer in the lower lid is a basal cell, and the left forehead is a carcinoma in situ. So I'll stop there. And with this high-risk patient, immunosuppression, and all these face lesions, what type of imaging workup do you start with? And if it were a non-immunosuppressed, how would that change your workup?
Alice, I agree. I have a lot of these patients in my practice too. And I think with, any rapidly growing lesion, I would just get a CT neck. We have a hard time, unfortunately, getting any other imaging at Vanderbilt in a extremely timely manner, but I could probably get a CT neck with contrast if he can tolerate contrast that day. And so that would be really helpful to me. I think that's all I would need.
Got it.
I would probably make a phone call pretty quickly to his transplant team to see if we could push down his meds dramatically. As
Agree.
Part of the workup.
All right, perfect. So here's a CT neck. You can see in the view here this lesion that's going to pop up on his face there. And then just concentrating in his neck next. There's no obvious lymphadenopathy. I didn't feel anything. I don't see anything on exam. And the question for me now is, well, what do I do with the neck? Would you get a PET scan to figure out if there was anything scary in the neck, or would you just go with this and take it off and work What would you do?
I would consider in these like rapidly growing immunosuppressed patients, I consider definitely sentinel lymph node. I do that on a lot of patients. If they have a high risk squamous cell, which I would think this was. And I can arrange that quickly. And then many times I would just do a primary resection and worry about reconstruction later, because I can make all of that happen quickly. And then the patient can wear a dressing, make sure our margins are great, and then see our facial plastic surgeon at a later date.
All right. So unlike Vanderbilt at Cincinnati, we have a lot of money, so we do get everything. So there's a PET scan here, which, you know, not surprising. You got those 3 lesions. The high risk population here, I've been burned a few times where they'll just met out real fast, and I didn't act quick enough, or I just didn't realize the occult rate of metastatic disease. So now I've been burned a few times, and it scares me a little. So the PET is also negative. And then talking about the management of the neck, we talked about sentinel lymph node. I like the thought of recon later, which I often do for melanoma and Merkel, but for squamous cell, I generally just rely on frozens and do the reconstruction at the same time. Would everyone just take off all 3 and just make it a whack-a-mole type of day for the face? Yeah, okay, cool. All right, so that's what I did. I'm glad you guys don't disagree. So I ended up doing a sentinel lymph node of that left cutaneous squame, resected, and then we reconstructed. So this is a, this is the sentinel lymph node scan. So it was injected, and when I'm going by, we do lymphoseek here at Cincinnati. Got a bright node there, and that's about it.
Out of curiosity, do you inject like all 3 areas kind of in 4 quadrants, or what do you
No, I inject 4 quadrants around the main lesion. That, you mean the main lesion, or are you talking about the other?
Oh, sorry, yeah, one of them was a basal cell, but there were 2
Yeah.
squames.
If it were, that's a great question, because the other one I got lucky, I guess. It was a carcinoma in situ, so I didn't really bother with that one, but I probably would have just injected a whole bunch and then see where that all drained to and gotten those lymph nodes out. So frozen margins for skin cancer, this is why I'm late. I just took this out today. Do you do specimen margins, tumor bed margins, or combination of both? I know, increasingly oral cavity cancer, we do specimen driven margins as opposed to tumor bed margins. How do people feel about this for cutaneous?
Yeah, I for as much as possible do specimen driven margins. Sometimes with some of these really massive tumors, you're doing frozens. I'm not gonna lie, I'll do skin and tumor bed based margins there, and then directed margins along my nerves if I have them there, or if I've had to take a nerve specifically. But for the most part, tend to bring them down and ink them all and do them off the specimen as much as possible.
Yeah, I agree with Adam. I guess the thing I never see in those papers is like whether you the methodology for taking those specimen margins. And so do you transect the tumor and then go kind of perpendicular at your transection, or kind of what is the preferred way of taking the specimen based margins? I usually just kind of go circumferential, but I have some other partners who kind of go perpendicular and then go en face to that.
We got this crazy researchers out at Vanderbilt trying to make us scan these in and then talk to pathologists over a big screen. I'm not even sure what I'm doing anymore. Kind of like, I'm not even sure what I'm doing. So if you find that guy, catch him. Now, yeah, in all truth, we're definitely trying to figure out the scanning business and trying to figure out how it works in. But on our, yes, so bisect and then do perpendicular from the bisection. And it depends on, obviously this is a nice round one, so the rounder they are, the easier that is. The more amorphous and it can be a little more difficult. But yeah, that tends to be the technique.
I take representative perpendiculars to areas that I'm concerned about, or the pathologist, when they bread loaf it, they look and they're like, oh, that's close there. And then like Adam was saying, like it's hard to get that perpendicular ear canal margin or the masseter margin, so certainly I like a combination of both, just so that the areas that I am concerned about, that I know I can very accurately go back to, which is kind of where I get it out of the tumor bed. But I think that from a pathologist's point of view, they want to know what that tumor looks like so that they can tell you accurately what your distance is right away. And I find that extremely helpful. All right, so the pathology on this gentleman, he had his enough nasal cancer was 3.6 centimeters. It was deep. There were no PNI or LVI. I had some close margins on permanent. The deep was 1.5. And that was basically because I was on the nasal bone. So it was a PT2 N0MX. The rest of the other excisions were fine. So the sentinel lymph nodes, you know what? I can't remember what I did in this guy, but would you do a frozen sentinel lymph node for cutaneous, just like you do in oral cavity, or do you defer to permanent and staged neck because you're already putting 4 holes in the face? And would you do the completion neck at the same time? If it was positive, sorry.
I think that given the negative PET that you have and the negative CT, I would defer to permanent, but that's typically what I do, because I'm only going to do a sentinel node in patients that I, don't have evidence that they have spread. And I just think if, like a melanoma, if you're looking for small amounts and really doing a sentinel node, then you need to defer to the permanent. And then he would have a secondary neck dissection.
In regards to the sentinel node too, I just had another question for you, for our panelists. Is anybody using the isoflurane green and the SPY for their sentinel nodes for these, or relying strictly on the our lymphoscintigraphy? Yeah,
I use methylene blue with it. I don't know if I love the methylene blue. It's like the only positive reinforcement I get all day. So I mean, that's what I do. I don't know if other people, well, recently I'd asked, I think Mike at Vanderbilt, or Kyle asked you, if we're doing methylene blue for oral cavity sentinel lymph nodes, because I was looking at the protocol. It doesn't seem like we're using that, but that's just kind of a side. I didn't have an answer to that either. So. Okay.
And
Adam, what are you using for your?
Not methylene blue or the SPY. I'm using straight up, I don't know, I think it's technetium or whatever they're using in the nuclear medicine suite these days. But nothing special from an identification standpoint. We use the NeoProbe.
Just confirming, everyone here uses SPECT CT in the head and neck when they're doing these cases?
Yeah.
Yeah.
And just backing up a minute for the sake of the fellows, kind of similar to Rob's question before, asking about which lesions you injected, what does everyone consider, we're calling this a high risk lesion. What does everyone consider a high risk skin cancer? When do you decide I'm going to do sentinel lymph node? When do you decide you're going to do imaging? When do you decide you're going to do an elective neck dissection?
It's a great question, because I tend to use the Brigham and Women's staging criteria, which gets you, I think, to a max of T3, but I use those risk factors, and so certainly want to at least get past 2 of them to get to a point where I'm at a higher stage, so advanced stage, that would lead me to think that a sentinel node should be done, and that's, statistically speaking, that's where you're going to reach your 15% threshold.
I was going to say, I also use the Brigham and Women's, but is anyone here using that like Castle Biosciences risk stratifier thing? I mean, I've had patients come into my office having already gotten it ordered from someone else. That always kind of throws a little curveball at me.
We've sent them specimens for research, but we haven't used it as a particular risk stratifier. We've just used the traditional staging as our risk profile.
Would it alter
Yeah,
your decision to do a sentinel lymph node or a neck dissection though? If someone came in, usually it's a dermatologist who's ordered it, and then the patient is just kind of like giving me this report and asking me to interpret it for them.
Yeah, I've seen a similar scenario here. It doesn't really impact too much how I think outside of our traditional clinical pathologic factors. Their data is interesting. It hasn't been prospectively validated. I'm not really sure what to make of it at this point.
That's kind of exactly what I say to the patients usually. It's kind of like my politically correct way of saying that I'm going to keep doing what I usually do.
All right, so we talked about radiation, but he elected for observation, and I did eventually get them to decrease some of that immunosuppression for him. I guess my last question here is surveillance, imaging, frequency, send him back to Durham, never see him again. How are people following high risk skin cancers in their clinic? Do you send them?
Can I ask one more question about the adjuvant therapy? So let's say you did elect to go to radiation. If you have a sentinel lymph node, will you radiate the neck, or will you radiate the primary alone in the setting of a negative sentinel lymph node?
We would do
Right.
the primary only is what we would do.
The primary only?
Mhm.
Yeah.
Yeah.
Yeah, that's what we would do too. And just, would you get a 3-month scan, watch him, or just let him free? Never see again. Never see him again.
No, I would definitely develop a surveillance plan. As it is for most of us at our centers, we have a 3 to 4 hour radius plus or minus where people are coming from. And I think that it's fair to the patient to use your peripheral sites of service or referring docs as part of that surveillance plan, especially for skin. I usually maintain a 1-year surveillance, at least with me, which I don't make it arduous for skin. I tend to do about 6 months after completion of therapy and after I've worked out the 3-month follow-up. And then after that, depending on who they're referred in from, I'll make a phone call and say, hey, can we ensure we're following these folks on a regular basis for, indefinitely, especially for skin. But I don't force them to make the trip down to the city. I try to be sensitive to their travel needs.
Yeah, so that's what I did. 6 months NED, send him back to Durham. I think I am going to see him in a year or two. They're seeing Durham anyway because they're high risk all the time and they're getting cancers all the time too. So I think I release them at one year unless they have limb problems, which usually happens in my scalp patients.
So you have the next one available too there,
Oh,
Alice?
yeah, you want me to do that one?
Yeah, that would be
Oh,
great.
Hey, Alice, real quick on
Hey.
that one, I'm curious on the group. If that one hadn't had a liver transplant and hadn't been immunosuppressed, would anyone have reached for immunotherapy based on the two trials that just came out last year and a half for this specific lesion? When do you give Jennifer a call and say, hey, I need some help here?
Well, this next case.
Okay, nice. Oh, good. I love it.
This is a Jennifer Cho type of case. So, all right, she's 94 years old. She's grandma here. She got a history of a Mohs on the right temple. It was removed. She has an enlarging right parotid mass, which is why she's being sent to me. She also has a history of DVTs in which she's on Coumadin. All of her children are physicians, it's always fun. Her facial nerve works. And she was sent to me. So here's her scan. I said right side, right parotid mass. The Mohs site is the right temple, which is well healed, looks great. But she has this regional metastatic disease. I think there was a reason she couldn't get contrast. And now she has a large tumor on the right parotid with lots of nodes, but resectable. But given the extent of the surgery, she's 94. She would have to be off her warfarin for a little bit. We thought she would be a great candidate for neoadjuvant. would everyone agree, or would people go ahead and try to take care of her surgically?
I definitely think that Sarah and Kyle would have sent this patient to me.
Perfect.
I think in this scenario, we would definitely have offered the patient neoadjuvant immunotherapy. And in fact, me and Sarah share a patient that sounds just like this patient. And the question was, if they got a CR, what would you do with them at that point? And the jury's still a little bit out on that. The standard of care would be to do the resection, but I think many of us are probably doing things that are probably not standard of care in that scenario, where, I will treat beyond what we did in the trial for 12 weeks, and I'll treat until basically they have plateaued their response or had a complete response. And then the question is whether or not you continue to treat. Do you radiate at the field, or do you just observe? And I kind of leave it, actually, I kind of discuss with the patient and I leave it a little bit up to them. The standard of care, the standard board answer would be that we would continue to treat for 2 years and then we could stop. Because it's given in the neoadjuvant setting, you could argue you treat the CR and then you're supposed to take them to surgery, technically speaking. But I think in a lot of situations, we wouldn't do that as actual practice.
All right, so she gets her.
Hey, Alice.
Go ahead.
Sorry to interrupt. I know we don't have a picture, and that's okay. But this is you're considering this a regional met, right?
Yeah.
Not because the Mohs is completely cleared.
Yeah, but it was in a very close proximity because she got the Mohs, but it never got imaging prior to it. So it was like 1-2 months later, then she started having this growth. Yeah, I would make a point to the fellows to point out that sometimes you'll have a patient come in with an erupting lesion out of the skin, and your first thought is this is a primary skin cancer, and oftentimes it's actually a node that just lost the battle and blew through the skin, and so they're slightly different in the way I think about them surgically. But I wouldn't change anything here. Just recognize whether you're dealing with the primary or the lymph node, because they're obviously two different, and they describe they're also biologically a bit different too.
And I think a very important concept for the fellows to understand too. So when you have this conversation in this setting with this 94-year-old patient, are you telling her you're treating her for cure? Or are you telling her you're treating her palliatively?
Yeah, and I should point out, right, neoadjuvant immunotherapy is not considered standard of care, right? So the reason for this is no, I mean
it's not.
isn't, because
I know. Jen, it's interesting you say that because whether you look at, so if you take the ECOG 3311, we would say that de-escalation of radiation in our TORS patients is not standard of care because it was a phase 2 trial. So a lot of these trials, like the Neil Gross trial, et cetera, all being somewhat phase 2, none of them phase 3. And so technically I agree, not standard of care, but in some of these cases, we also have to recognize that the standard of care is through expert opinion.
Right, that's what I was going to say, because actually I was involved in that trial. So the standard of care is not neoadjuvant immunotherapy. However, we still do it quite a bit. The reason why it's not considered standard of care is just because the endpoint for the study was basically response, pathologic response, which is not considered a validated endpoint for the FDA. But most of us believe that it actually has benefit for the patients in long-term survival. It's just that technically speaking, the way the study was done and the endpoint is not considered enough by the FDA. So I will point out that the patients that did get neoadjuvant immunotherapy, though, and they had a path CR, a year out, we have not seen any of those patients recur. And the data beyond that is not mature. So it does seem to suggest patients have, a recurrence-free benefit, but it's not technically what the FDA is accepting, so it's not considered standard of care. That being said, I've never had difficulty getting a neoadjuvant immunotherapy approved for patients from an insurance standpoint. So But that's just to keep in mind, like the board answer is technically supposed to be that this is not considered standard of care, but many of us we do this. My main criteria is really like whether or not we would decrease morbidity for the patient, especially. So, and partly because that is not considered the standard of care. If the patient is going to have an easy resection, then I often will just tell, Sarah and Kyle just to go ahead and take them to surgery if that is the case. The other considerations are if the patient doesn't want to go to surgery, they want to see if this will help them. Let's say the orbital extent that's going to be within their future, like all of those things are taken into context as to whether or not we would give a neoadjuvant immunotherapy. So we give it, to a fair number of patients, despite technically speaking, it's not standard of care.
Just to echo TJ's point, how often would you do radiotherapy though? Was that considered in the algorithm initially, or even after neoadjuvant immunotherapy?
So the
No,
study,
I mean,
the study
Go
did
ahead.
not permit patients who had prior radiation to that specific, the site of interest. So that study did not allow radiation therapy. So that question remains unanswered.
And so I'll go back to my original question then. Are you telling this patient this is a curative intent treatment, or anything short of surgery, something including surgery is palliative because of, well, I'll leave that up to the panel.
I think sometimes surgery is palliative too, because she was in a significant amount of pain. I actually did have that conversation. I have that conversation with all 80 and 90-year-olds, that a lot of, while I'm trying to cure them, it is also, there's a huge palliative component to it too, because once that busts through, now you have a big open wound that no one wants to be around you for. But I think that those are important conversations.
Yeah, I think it's important to know the limitations of the data, particularly in the adjuvant setting. Whether or not it's standard of care, I think it'll always be a choice an option for patients, but the standard of care stuff around adjuvant radiation therapy, continuing on immunotherapy for another year, and how we deal with the pathological CRs, I think has a lot of data we still need on that. And I think there's some places that are kind of treating the path CRs by withholding radiation therapy, which I think the early data suggests that we, could potentially do that. But if we start getting a lot of late failures, we may have to reevaluate that. So it's important to have a trial, I think, that really answers those questions and not rush forward too quickly, because we've seen that obviously with other things like Cutaneous and HPV positive disease, right? We think something's going to work out, and it turns out that when the big study's done, it actually doesn't pan out.
Yeah, I think Neil Gross has a study in moving through energy currently that's supposed to look at this question in a more validated way.
So
yeah, that's gonna be registrational.
Yeah.
What I've seen recently, and it's a conundrum, is that they'll have side effects from the therapy. Then they stop the immunotherapy, then they start, and then they progress. So this is her September scan. She's gotten 2 doses at this point. Sorry, that was kind of fast, but I think I scrolled back up. She's in a significant amount of pain. The arthritis apparently was so bad that she refused to go back to get immunotherapy, got better on steroids, and then I convinced her to just get a second dose. So that's kind of what she didn't get a 3rd cycle. I've had a couple of patients now that they're progressed, they didn't respond, right? Or it wasn't in an ideal schedule that they got it, and she has this disease now. It's really beginning to blossom in that, and this was just a couple weeks ago. So I asked the panelists, what would you do at this point?
Yeah, I think this is a good demonstration. I mean, neoadjuvant's exciting, but you have to counsel patients that, 2/3 of people are going to have a really significant response. 25% will have stable disease, and 10% will progress. And that's just sort of rough estimates when I tell patients. And so, this is obviously concerning. I can't quite tell, Alice, is this considered surgically resectable? But if
yeah, no, I don't think, no, not with like real margins. It would, back to
Okay.
Rob's question of whether or not this would be palliative at this point, because she's in a lot of pain from a disease that is not responding to non-surgical means. Do you just say hospice at this point, or
We use our radiation oncologists level out of the quad shot, the hypofractionated, radiation regimens in those settings where it's like it's not resectable. We're not really going for cure, but we can probably achieve some meaningful local regional control and symptomatic control.
we did that? She ended up with pneumonia this week and got hospitalized. So I mean, the stars are telling us that, you know, we're not going to beat this. But, you know, other than her though, I do really want to ask everyone, you know, I have a few patients out there, they're just not tolerating immunotherapy like we thought they would. Maybe they are responding a little bit, maybe we're not giving enough time, but it is a conundrum because now I'm the one who has to do a more morbid surgery, right? So it's a tough scenario.
Yeah, I usually have a conversation with them about, you know, even though our response rates are very high, I always tell them, you know, there's still about, you know, 25% chance or so that they're going to have progression and then they become unresectable, or it'll be a more morbid surgery, it'll be worse than before. And so they have to weigh that risk as to whether or not they're willing to risk that. And this patient, because the patient was like 94, it's a little bit of a different question, considerations of the clinical context for this patient. If she had responded, you know, that technically could have been curable because she could have died by when she's like 95 just because of her age from something else, right? So for her, that could have been enough. But in this case, because of progression, I will say that we also do see pseudo progression in cutaneous squam, meaning that the tumor can get larger before it gets smaller. So we can see that. I mean, all this degree of change is probably progression. And in that case, then I usually do advocate for either surgery if they're still resectable versus like they mentioned before was radiation therapy.
Dr. Weed, I see you're online too. Do you have any comments that you would like to add in regards to any of these cases?
Yeah, I was just actually typing in the chat, but you got to me first. I think this last point is really the great point, which is that immunotherapy is not without risk, particularly in the neoadjuvant setting. And that risk includes progression and adverse change in the surgical plan in a resectable patient. It also includes autoimmune side effects, which are not insignificant. So until we have really an established, well-defined standard of care, it's just important, particularly for the fellows, to understand that if you're proposing something like this, or a patient comes to you where this has been already proposed to them by their treating physicians, that you have to have you have to temper your enthusiasm with a very thoughtful discussion about the risks associated with this approach in your informed consent with the patient. Again, I think neoadjuvant immunotherapy is going to be standard, I'm sure quite soon for well-defined groups, and hopefully those well-defined groups will be extended. But informed consent involves clear eye towards what may not go as well as we all hope it will.
Well, thank you very much. I thank all our panelists, and I thank Dr. Brody and Dr. Tang for our great presentations. And sorry we couldn't get to your last one there, Rob. But I think this was a great discussion, and I appreciate everybody's participation in this. Dr. Mannion had to run back to the OR. He had to do some vein grafting. Dr. Netterville, I guess, left him no veins in the neck, so he's going to be busy working tonight. So thank you again. Dr. Moore, do you have anything else to add?
Yeah, no, I just wanted to thank all of you. It was a great session, and I think this, of all of the sessions we have over the course of the year, this is one that really, this and the melanoma one, there's just so many changes in how we're managing these diseases. I think back from when I was in training and early in practice, and it's completely changed the discussion and approach that we have to these patients. But yeah, I really want to thank you, Rob and Kyle, for organizing this, and Alice and Rob, great presentations. I know everybody's pulled in a million directions, so I appreciate the kind of team-oriented approach and people stepping in. Vasu and Jin Cho, thank you so much for providing your perspective, and Adam and Sarah, thanks for taking the time to join us. I know Don Weed and TJ were also on the call as well, and as were Arnaud and Tony Eskander. I apologize if I missed any of the other faculty. So thank you all so much for joining us. Our next session will be in New Year, January 10th. It'll be on advanced and unusual salivary malignancies. So thanks again so much to everybody for chiming in. Have a great holiday season. We'll see you in the new year.
Thank you.
Thank you,
Thanks
guys.
all.
Take care.
Thanks.